And final talk of the day is, before we have the moderators, the future directions in PSC research. Dr. Ulrich Beuers, the professor of gastroenterology and hepatology at the Academic Medical Center at University of Amsterdam.
Thank you very much, Mr. Chairman, ladies and gentlemen.
And Mrs.
And Mrs. Chairman, but you introduced me. It's a real pleasure and honor for me to be invited here to give this talk. This will be a personal view of mine, and the selection of subjects will also be personal. May I have the first slide, please? Okay. The introducing slide, I like it because it shows us the problem of patients with primary sclerosing cholangitis. It's from Gideon Hirschfield and his colleagues from a Lancet review 3 years ago, published 3 years ago. And it shows us the different stages our patients go through. This is an early stage here. You see the bile duct still intact, and you see inflammation around the bile duct, and this is the scheme here for. The second stage then is you already have scar tissue around the bile duct. And what we want is to make an early diagnosis and to avoid formation of scar tissue. And the scar tissue, this is the reason for this pruning of the bile ducts, the stenosis of the bile ducts. And in a late stage, these bile ducts also disappear. They are heavily damaged and then they disappear. But we need our bile ducts for an adequate liver function. The liver has to secrete bile into the bile ducts and then into the intestine. So all our efforts should be to identify our patients in the early stage of the disease. And so all methods in the future to identify our patients early, to have early disease markers, would be very important. I have now selected 4 subjects: epidemiology, diagnosis and screening, pathophysiology, and treatment for future directions in PSC research. And you may have seen the data this morning. This is in my view, very carefully performed population-based cohort study from Kirsten Boonstra and Cyril Ponsioen from Amsterdam. I'm also from Amsterdam. But I want to mention it because it's so important to apply the good methods to study epidemiology. And what they showed, and I printed it here in bold, is that the transplantation-free survival in 590 patients was 21 years in the mean. And this is different from what everybody had learned in the past when looking at the internet or having informations on primary sclerosing cholangitis. They also showed that in transplantation centers, the mean survival was lower, but this is the transplantation-free survival was lower, but this is to be expected because patients who already have complications go to a transplantation center for the first time. Also, the rates of cholangiocarcinoma were those which we know. 7% in this study, patients were followed over 90 months in the mean. And in continental Europe, we treat our patients with ursodeoxycholic acid, and you see that here 92% were under ursodeoxycholic acid. So also for the future, very carefully performed and with the right methodology performed epidemiological studies, I think are very important to do also in other areas of Europe, the United States, Northern America, or Asia, to have comparisons. Diagnosis and screening. I already mentioned we need to make the diagnosis early during the disease, to have options to intervene early in the disease process. This is the definition which from the European guidelines, and I had the honor to chair the European guidelines on cholestatic liver diseases, and we said a diagnosis of PSC is made in patients with biochemical markers of cholestasis not otherwise explained when MRCP shows typical findings and causes of secondary sclerosing cholangitis are excluded. This sounds simple, but we already, when we have our markers, MRCP is pathological, we already have scarring of the bile ducts. So we actually want to be earlier in the diagnosis, but this is the actual standard, and the American guidelines are the same. This is a patient who came with jaundice and had this cholangiogram here made by ERCP. And 15 years ago, he would have had the diagnosis of primary sclerosing cholangitis. We have learned in the meantime more about sclerosing cholangitis, and that there are many different subtypes of sclerosing cholangitis, and that not every patient with pruning and dilatations is a patient with primary sclerosing cholangitis. And when you have this a patient with these cholangiographic features, you have to go through a long list of alternative diagnoses of sclerosing cholangitis before you can make the diagnosis of primary sclerosing cholangitis. And this is sometimes, this needs particular attention in my view. I will give you one example, and this is related to this patient. 10 years ago, we didn't know the disease IgG4-Associated Cholangitis. It was defined in 2007. We now know that about 10% of our patients with PSC do not have PSC but have IgG4-associated cholangitis, and this has consequences. The patient with IgG4-associated cholangitis, like the PSC patient, the majority is male, but he's in the mean 20 years older than the patient with PSC when he gets the diagnosis. Jaundice, weight loss, abdominal complaints are typical manifestations, and he can have localized organ swelling as one of the criteria, and here you see the swollen pancreas as a sign of another disease, autoimmune pancreatitis, which goes together with the IgG4-associated disease. And he can have other organ manifestations. In our patient, this was easy to do, because the diagnosis was easy to do because he had high IgG4 levels in serum, which were 8 times elevated above normal. PSC patients also can have IgG4 levels above normal, but this 8 times, they don't reach 8 times, less than 4 times. This shows in a large cohort of 125 patients the difference between IgG4-related disease and PSC patients regarding IgG4 levels. You don't have to know exactly what is IgG4, but it's an immunoglobulin. But you see there is considerable overlap between the PSC patients here and the IgG4 patients in a part of the cohort. So with this marker, you can't make really the difference. What we need are excellent tests, accurate tests, to make the difference between these diseases. We had an idea from coming from beekeepers who have high IgG4 levels, and they are directed, these IgG4s are directed against the toxin of the bee. We thought maybe our patients, IgG4 patients, also have clones like the beekeepers directed against certain antigens which we don't know. And indeed, we found clones in the IgG4 patients, but not in the PSC patients. And when you ranked them, you could make a difference between the two, which was could completely differentiate these two groups. But this technique of next-generation sequencing is much too expensive. It takes a long time, lots of workload. So our fellows developed a very simple, cheap sense qPCR test with the same background, intellectual background. And with the qPCR test, with the cheap test, affordable test, they reached almost the same result. So they could separate these two diseases. So in this case, we apparently have reached a marker which can easily make a difference between these two diseases. And this was supported by PSC partners, and I thank the PSC partners organization for their support. And I think for the future this will have impact on making a good diagnosis in patients with sclerosing cholangitis. The second example is cholangiocarcinoma. It also can mimic primary sclerosing cholangitis. Often it's the consequence of primary sclerosing cholangitis. But how to recognize cholangiocarcinoma? Here we are by far not that far as we are now with IgG4 disease. This is a list of criteria which we use to make the diagnosis, but it's not that easy. A brush at ERC can recognize the disease in 30% or in 40%, and when you are doing 2 brushes, you are at 50%, and 1 more brush is 60%, and you do a biopsy, you have 10% more, but you are never sure that you have a high percentage of failure to make the diagnosis. We have a number, for the future, we have a number of techniques which are evaluated already for a time, but still there is no breakthrough. So here we really need better tests to predict cholangiocarcinoma in patients with PSC. Also for other screening methods, annual or biannual colonoscopy in the presence of IBD, annual ultrasound for gallbladder and liver. We do that in our patients, but the evidence for the ultrasound is still low, but these are measures which we also will do in the future and which we recommend for the future. We heard already about looking at progress of the disease, and you heard from Professor Chazouillier about the elastography. And we think this has future, and this is one paper of the group was published in Gastroenterology 2014 with promising data. In the future, this may be one step to evaluate the progression of disease by a simple non-invasive method. Magnetic resonance elastography may be the more accurate, but in Europe we look very much on COAS, and this is very easy to do during the visit of the patient. When I talk with the patient, I do these measurements very easy. So we do a European so-called FICUS study in the international PSC study group, and many centers are involved, and we will see whether this has also an impact on follow-up of our patients. Pathophysiology, that's a difficult subject. We want to understand how PSC develops, and only when we really understand the mechanisms, molecular mechanisms, how this disease develops, then we can really also find adequate treatments to tackle this disease and early in the disease stage. What do we know? Very, very superficial. I don't have the time to go into detail, but Tom Carlson and colleagues have done a lot of genetic studies which helped us to understand better the genetic background of the disease, but it didn't help us so far to understand the real mechanisms, how the disease develops. There is the discussion on the microbiota. 70% to 80% of our patients have inflammatory bowel disease, and there is speculation since 30-40 years that it's bacterial pathogens like lipopolysaccharides. These are wall elements from bacteria from the intestine, which may reach the liver and then may induce inflammation in those patients who are genetically susceptible for this inflammation. Also, the role in general of the microbiota is still unknown and will be investigated in detail during the next years, an important subject. Apparent homing of intestinal T cells, very attractive hypothesis by Bert Eckstein and David Adams for the first time described about 10 years ago, you can correct me. It has shown that there are lymphocytes, the white cells, defense cells, which belong to the intestine, but in PSC patients they also sit in the liver. And they are not sitting in the liver in my case, and in our chairman's and chairwomen's case. Only in PSC patients. Why is that? Why are they getting there? There are so-called adhesion molecules which are only found in the intestine and in PSC patients also in the liver, which attract these T cells going to the liver and infiltrating the liver. They may play a role in this process. This is a very interesting, you don't have to understand the whole picture, but it shows you this is an interesting concept from Dr. LaRusso's group from the Mayo. We all of us here in the room will have during our life injury of our cholangiocytes, as we have scratch wounds of the skin. But in most of us, the skin is healing and nothing is happening. But in our PSC patients, they don't have apparently the ability to heal these wounds in the cholangiocytes, and we don't yet understand exactly why they don't do that. There is a common cause of when you have injury inside the bile ducts of the cells which cover the bile ducts, and usually there are mechanisms, defense mechanisms, which lead to complete recovery of our bile duct cells. But in our PSC patients, this is different. They have an aberrant reaction, and so they get, what can I say, easily overactive cholangiocytes, which express all kinds of inflammatory markers and secrete these inflammatory markers. And so this is a cell which is not good for the environment around the cell, and they among others, induce fibrosis, formation of scar tissue. So this is the wrong way. What we have to do is block this way and lead also in PSC patients, give them the chance to heal the wounds. And this we have to do with future medications. Let me give you one more step. Sorry for these slides, but it's just a simple message. What we have learned is that our cholangiocytes, and they are the target in primary sclerosing cholangitis, these cells which cover the bile ducts, and they, whatever stimulus they get from the nerve, from the nervus vagus, from hormones like secretin, or from the bile acids in the bile, they always react with bicarbonate formation. And why do they form bicarbonate? They form a sort of umbrella at the surface of bile. And in human bile, there are high millimolar concentrations of bile acids, and no other cells in the body survives these high concentrations. These are aggressive molecules. Only the cholangiocyte, so this cell. And what we think is, but this is still hypothesis, we think that our cells need this bicarbonate, what they secrete, to keep the milieu alkaline and keep the bile acids as bile salts, loaded, negatively loaded molecules. As soon as they are not loaded, they can invade a cell without problems. But this molecule cannot do that. So the bicarbonate would serve as a protective umbrella against invasion of toxic bile acids. And these then in the cell induce changes which lead to finally to death of the cells and to a fibrosing cholangiopathy. And this is scar tissue around the bile ducts. Interestingly, the group of Dr. Carlson showed that there are PSC risk genes which affect this umbrella. And one of them is a bile salt receptor, and the other one is an enzyme called fucosyltransferase 2. You don't have to remember that. But they both are relevant for the stability of this umbrella. So maybe there are molecular defects which may set our patients at harm to develop damage of the cholangiocytes. And the last step which I want to mention is treatment. And treatment, this is, and therefore I gave you some ideas about how we think the protection mechanisms in the bile ducts act in our view. but we have to know much, much more about it. And treatment is directed to stabilize these mechanisms. You have heard the discussion on ursodeoxycholic acid, and there are different views on it. I told you that in continental Europe, France, Germany, Netherlands, most of our patients are under ursodeoxycholic acid. Why are they under ursodeoxycholic acid? That's a natural bile acid. We all have it. It's since 1,000 years used by Chinese as dried bear bile when patients are jaundiced. It has no side effects when it's given at therapeutic doses. We think today, after 25 years of intense work, we think that the key mechanisms are stimulation of hepatocellular secretion and stimulation of cholangiocyte secretion. And this means bicarbonate secretion. The cholangiocyte secretes bicarbonate. And this would mean that urso helps to stabilize this bicarbonate umbrella. It also reduces bile toxicity, and it has anti-apoptotic effects against dying of the cell. This was a very early study, very small, a pilot study, which we performed. It was my first study to set up and perform. And I was very much under the impression of this small trial, because alkaline phosphatase improved by 50% within a year in these patients. And also the other liver tests all improved. Histological markers, I was blinded by the pathologist, and I could separate all placebo patients into the one group and into the other group, the urso-treated groups, by the amount of infiltration around the bile ducts. But this is personal, but it has influenced me. So, but we have to go with the rules and to look, do we have survival benefit? And this is the largest study from Scandinavia, and you didn't see a significant difference. You saw a trend for the urso-treated patients after 5 years, but it was not significantly different. But this trial, the organizers of the trial had calculated that they will need almost 350 patients to show a difference. And they were finally, major effort, but they were finally able only to analyze 198 patients. So it was not enough patients to be studied. And another thing in this trial was that there was no significant effect on alkaline phosphatase. This was in contrast to about 10 pilot studies which had been performed during those years, where alkaline phosphatase improvement of 30 to 50% was observed. And the remark on the Lindor study from the last talk, this was a double dose of ursodeoxycholic acid in PSC, and the effect why it went wrong with more varices and more patients on the transplantation list is probably that this dose for the fibrotic cirrhotic liver is too large, and these patients cannot get rid of, for mechanical reasons also, this is speculation, for mechanical reasons also, of all the bile. But that's the state we have at this moment. The European guidelines said that the available database shows that urso at therapeutic doses improve serum liver tests and surrogate markers of prognosis, but does not reveal a proven benefit on survival. The American guidelines in 2010, under the impression of the trial by Dr. Lindor, which went wrong, said we recommend against the use of urso as medical therapy. And the revised American guidelines says UDCA in doses above 28 milligram per kilogram a day should not be used for the management of patients with PSC. So the high dose should not be used, and we completely agree with that. High dose should not be used in PSC. What are other options? Shortly, these are options, in my view, from looking at the pathophysiology. NOR-URSO was already mentioned. NOR-ursodeoxycholic acid is a bile acid with one C atom less than urso, and it is the strongest stimulus of biliary bicarbonate secretion which we know in the human being. This has been shown by Professor Hoffman from San Diego about 10 years ago. So this is his main effect, stimulation of bicarbonate secretion. The other drug which is, in my view, of interest are PPAR alpha agonists, fibrates. And the Paris group of Dr. Chazouillet is performing studies on that. And also here, if the Yale group, Professor Beuers, is right, they showed that in rodents, biliary phospholipid secretion is increased. And what does it mean? Biliary lipids bind bile acids, potentially toxic bile acids, and put them into my cells, and so the bile acids cannot attack the cells. So you have a kind of a protective mechanism at the level of the biliary tree. There are other substances. Vedolizumab is an antibody based on the idea of Dr. Eckstein to get rid of the T cells, intestinal T cells, and that they don't target the liver. And we have to wait for first results. And endoscopic dilatation, we mentioned that, that's an endoscopic measure. We still don't know whether stenting or balloon dilatations are the good way to go when we have dominant strictures, and we will see the outcome of the study very shortly. PPAR alpha agonist and FGF19 homologs, the NGM compound, it has, in comparison to obeticholic acid, no proliferative effects, and so my personal view, I prefer the compound. Last point, and then I'm done. We have the problem, for the patients have the problem, fatigue, pruritus, and abdominal pain. I don't comment on fatigue. This is an important issue, but we do not understand a lot about that important issue for the future. With itch, we are a little bit further. We know that potential pruritogens are secreted into bile, that they accumulate in the systemic circulation, and that they affect the endogenous serotonergic and opioidergic system, all from clinical observations, and they are biotransformed or in the liver or in the gut. And this all happens when the bile ducts are occluded or when the hepatocyte does not function adequately. In recent years, we have identified lysophosphatidic acid as one of the components most possible to add to the pruritus. It's the only, and the enzyme which forms it is autotaxin, which we all have in blood. And this is the only molecule ever shown which really strictly correlates with intensity of pruritus. But we know there is a second factor X, and Gideon Hirschfield has mentioned already there must be something in bile, because when I do a nasobiliary drainage, the itch disappears very fast, and we have to find this factor X, and this has also major priority. And thereby, I'm at the end of these personal, I think, issues where I think we need to do more research in the next years. Thank you for your attention.